Hello everyone, I am Dr. Karthik, endocrinologist from Cochin. So today we are going to discuss a case scenario in which it is a 58-year-old person who is diabetic for short duration, obese, hypertensive, hyperlipidemic on statins, and has obstructive sleep apnea. So on examination, he was also found to be having a heart rate of 60 beats per minute. His A1c was 8.3%, eGFR of 70 ml per minute per 1.73 meter square, LDL was 70 milligram per deciliter, and liver enzymes, both AST and ALT, were elevated to approximately 2 times the upper limit of normal. He is on currently metformin 2 grams per day and adequate doses of lisinopril and metoprolol with aspirin and atorvastatin. So we are going to discuss how this patient needs to be managed. Initially, even before going on to the management, we definitely require few more details as to the family history of diabetes, cardiovascular disease, renal disease, the first part. Second part, why and when was aspirin started. Third part, we would also require microalbumin excretion rate, that is albumin excretion rate if possible, in order to quantify the albuminuria in that person, along with evaluation of fundus, so that we would be completing a full circle of microvascular complications. So after having known this, next comes the management of the patient. Initially, even before diabetic management, as all the landmark trials have been telling us, it is a multiple risk factor reduction that is going to help us. So hypertension, hyperlipidemia needs to be adequately controlled, and also since he has OSA, that needs to be adequately treated. In fact, that per se, treating OSA per se would reduce HbA1c to the tune of 1%. And we very well know that based on the given details, the hypertension is appropriately managed and hyperlipidemia also has been managed. So only thing is initiation of CPAP therapy for OSA. Now when we come to diabetes management, here is a patient who has not had any atherosclerotic cardiovascular diseases, but he has several risk factors as has been already listed. So typically, based on the ADA flowchart which everyone is familiar with, he doesn't qualify for the first line branching, it is treatment or initiation of GLP-1 analogs or SGLT2 inhibitors based on ASCVD or high risk factors. Why I am saying high risk factors is because according to the guideline, it is patient aged more than 55 years with documented stenosis of any of the end arteries of more than 50%, which is not the case, which we know. And as the evidence goes in all the major trials like Canvas and the Declare-TIMI trial, those who had multiple risk factors did not have any benefit in 3-point MACE, nor cardiovascular death, nor in reduction of MI or stroke. So for him, ASCVD risk factors are there, but it doesn't qualify so that he requires initiation with SGLT2 inhibitors or GLP-1 analogs. The first branch is out. Second, he doesn't have obvious cardiac failure. He doesn't have obvious renal failure. The second branching comes with the risk of hypoglycemia. Since his short duration of diabetes, that is not a concern for us. If cost is not a concern, since he is obese, it is ideal that he be started on GLP-1 analogs or SGLT2 inhibitors. Here comes the role of long-term benefit and risk. We know that GLP-1 analogs are exorbitantly highly priced, approximately 4 to 5 times that of SGLT2 inhibitors. Second thing, SGLT2 inhibitors, specifically empagliflozin, has 2 doses that has been shown to be beneficial, 10 mg and 25 mg. 10 mg dose has clearly given the same benefit as of 25 mg with respect to 3-point MACE. So here is a person who could be very well benefited with empagliflozin 10 mg per se. It's not a contraindication for other SGLT2 inhibitors, but still off the lot, this would be suiting him. First part. Second, we know that the SGLT2 inhibitors reduces the A1c approximately to tune of 0.8 to 1%. So even if we start SGLT2 inhibitors, still the A1c would reduce to somewhere around 7.3 or 7.4%, which we very well know that is still inadequate in such a patient who has only short duration of diabetes, to whom HbA1c should be somewhere, or we could aim HbA1c to somewhere around 6.5 to 7. So here is an ideal candidate in whom we could add on SGLT2 inhibitors plus another agent. Off the lot, DPP4 inhibitors seems to be weight neutral and also beneficial in reducing the incidences of UTI in combined to SGLT2 inhibitor. This combination has reduced chances of UTI or genital infection when compared to individual agents or when compared to agents that has been started one by one. So that is the second part. When we are talking about pioglitazone sulfonylureas, we know that weight is a concern, and though pioglitazone has a cardiovascular benefit, still other factors like bladder cancer risk, which is anecdotal still, and the presence of fractures on long-term basis is a detrimental factor. And we very well know that AGIs are not appropriate in such a person, and before jumping on to the injectables, this could be an ideal choice. So in summation, in an young or even in an elderly individuals who have short duration of diabetes, in whom we are wanting to achieve very good glycemic control, even in the presence of risk factors which doesn't qualify enough to start on SGLT2 inhibitors or GLP-1 analogs, presence of obesity per se, and if there is presence of microalbuminuria, that would qualify adding on a combination of SGLT2 inhibitors and over and above DPP4 inhibitors if we want to achieve a much lower target. That is, if we are wanting to target a HbA1c reduction of more than 1.5 to 2%. So I thank you for your patience.